Hello, my name is Imrana Qureshi and I'm a paediatric haematology consultant here in Oxford, and I'm really just going to go through acute complications of sickle cell disease, mostly relating to pain. So the main types of sickle cell disease, as you can see, are mostly where there is homozygous S. This is a beta chain variant. When this is inherited together, this causes sickle cell anemia. But there are also other beta chain variants when inherited with S can cause sickle cell disease. So sometimes there's a little bit of confusion about the wording around this, but SC disease stands for sickle cell disease inherited with a C chain, which is a beta chain, but it's a C hemoglobin, and it results in sickle cell disease. Also, sickle can be inherited with beta thalassemia and result in sickle cell disease as well, because you effectively have two beta chain variants which together cause sickling and result in the phenotype of sickle cell disease. In terms of the typical blood film, you can see that there were sickle cells on the blood film here, which are these long elongated cells, and this is a result of the sickle hemoglobin polymerizing in conditions such as deoxygenated states and states of stress. And also you can see that there are high retics because there is a constant hemolysis that's going on. This can also result in a high reticulocyte count and also patient to be jaundiced. This is an ongoing process in terms of the sickling, and this tends to get a lot worse during the so-called crises where there is increased sickling. But having a look at the blood film does not help you differentiate between whether a patient is having a crisis or not, as this is an ongoing process in the patient, which gets worse at times of crises. So the cause of the occlusion that we see in sickle cell is not just because the sickle cells get stuck in the blood vessels. It's because of a relationship that they have with the endothelium in terms of causing an inflammatory state and stickiness. So there is an increased inflammatory response in terms of sickling, which results in vaso-occlusion, but also a raised white count, a raised platelet count, altogether cause a very inflammatory scenario, which then therefore results in vaso-occlusion. There's also other physiological events that occur, including fewer vasodilatory molecules and the depletion of nitric oxide, which also results in depletion. And just as an aside, you can see that why these areas are therapeutic targets. So hydroxyurea has many methods of action by not just reducing the white cells and the platelets as a sort of cytoreductive agent, but also increasing the F and the bioavailability of the nitric oxide. And other newish treatments, crizanlizumab, work again at this endothelial level, and glutamine as well can reduce oxidative stress. So in terms of the complications in children, the most common complication we see is pain, but also that can lead on to chest crisis, which is the second most common problem that we see in children. Younger children can develop splenic sequestration, and stroke used to be a big problem in these children before we started doing transcranial Dopplers as surveillance. The chronic problems ongoing include delayed growth in puberty, but also the problems which they lead on to into adulthood, resulting in renal dysfunction, cardiac dysfunction, Infection is also a big risk in these children and in all patients with sickle cell disease in view of the hyposplenism, which is why they go on to penicillin prophylaxis. So the symptoms that we see early on are dactylitis. Usually we don't see symptoms till about 6 months of age because the children have fetal hemoglobin, which then switches to hemoglobin A, usually by about a year of age. And quite a unique symptom in children is dactylitis, which includes probably sickling and vaso-occlusion of the fingers and the hands, which is treated in the same way as a painful crisis, as you can see in the pictures there. So vaso-occlusive crises present with pain. They can present with fever. Bone pain is the most common feature that we see in children, but they can also have infarction of the gut. They can have liver and spleen sequestration and chest crises involving the chest and lungs. And the distribution of pain can depend on age. Typically, 1-year-olds present with dactylitis and splenic sequestration. As you get to the preschool age, long bones can be affected, including arms and legs, and they can develop acute chest syndrome. And in school children, abdominal and back pain can be a prominent feature and an area in which pain can be seen, as well as acute chest syndrome. Vaso-occlusive crises can occur without any precipitant, but they can also occur due to dehydration, infection, exercise and cold, and emotional stress. So probably around 50% of children who present with a painful crisis may have had one of these events. The main way to treat pain, you have to remember that pain in sickle cell disease is an emergency. We go according to the analgesic ladder, and we often tell parents to give paracetamol and brufen at home, and then when the child comes in, they will need oral morphine within 30 minutes of presentation. We tend to give maintenance oral hydration just to make sure that the patient is adequately hydrated. We only give oxygen if the saturations are less than 95%. And if there is fever or concerns that the child is unwell, we would treat with antibiotics in case there's a concomitant infection. This explains this analgesic ladder, which we go from paracetamol and brufen, as I said, and then moderate pain relief would require more than just a non-steroidal and paracetamol, and we are going to have to give an opioid in order to help control the pain. So sickle cell is an emergency, and this is a nice guidance which gives us some guidance about how to treat acute painful sickle cell episode. And ideally, you will listen to the patient because the patient will know that this is more like sickle pain than any other pain. Our patients do have individualized assessment at presentation, but on the whole, most of them are on a regular pain plan relief, which is Oromorph. So most children will have had paracetamol and brufen, and then we would give Oromorph. It has to be treated as an emergency, and pain has to be offered within 30 minutes of presentation. And the reason for this is because not only is the pain episode distressing, but it's really important to get on top of the pain episode, because once you're on top of the pain episode, then the patient is less likely to develop further complications such as splinting and chest crises. Also, it's very important to give patients incentive spirometer, and this just allows them to take adequate breaths so that they are not going to splint and increase their risk of chest crisis. And it's also really important to just remember that we don't give codeine in children anymore because of the risk of them being slow metabolizers, and therefore their risk of obstructive sleep apnea is increased. So all of these patients will have oral morphine, and if the oral morphine isn't controlled, doesn't control the pain, they will go on to receive intravenous morphine, but never as a bolus. We always give this either as a patient-controlled analgesia continuous infusion or a nurse-controlled continuous infusion. And the main reason to treat painful crisis promptly is to avoid acute chest syndrome, which can happen due to splinting and immobility. And this is the most common cause of acute death in sickle cell disease and is an emergency and needs to be treated quickly and adequately. It's caused by infection in a third of cases. So the way that acute chest syndrome presents is with chest pain, although it can be painless. So the most important clinical criteria is hypoxia. Patient will be short of breath, tachypneic, and have markedly low saturations and may not have pain at all. And a chest x-ray will show bilateral changes on the chest x-ray, as you can see here. And sometimes it can be difficult to say whether this is infection or chest crisis, but often with these patients, despite having antibiotics, they still remain hypoxic and get increasingly worse. And it's multifactorial etiology, including vaso-occlusion, splinting due to pain, hypoventilation. Sometimes there may even be pulmonary infarction due to thrombosis and an inflammatory state, and hepatoembolism. And infection is often a precipitating factor in children. So the way that we manage acute chest syndrome is to monitor the patient very carefully, give oxygen, can give fluids, but really watch for overload. Incentive spirometry is important to increase the lung capacity. Giving antibiotics, cefuroxime or ceftriaxone, as well as clarithromycin to cover all of the usual respiratory infections. And then, most importantly, to monitor the saturations really carefully. These patients will often need high dependency. It's usually better to transfer them early, otherwise transfer can become very difficult in a hypoxic patient because you do not want to ventilate these patients if possible. So it's better to transfer them early, bring them to HDU. If they aren't improving, then you will need to consider a blood transfusion. Blood transfusion is very commonly required in this situation, but we never transfuse over 100 grams per litre. But effectively, if the patient's hemoglobin is around 50 or 60, which is often what happens when they are this unwell and they are have a hemolytic and a painful crisis, then transfusing them up to 100 is usually adequate and has been shown in trials to be as good as exchange transfusion. However, if you top these patients up to 100 and they still remain markedly hypoxic and not improving, then they would go on to have an exchange transfusion in order to try to bring their sickle percentage less than 30%. Just doing a top-up can often reduce the sickle percentage to about 50%, and that may be enough to switch off the whole process. But if they're still not improving, then you may have to go on to have a full exchange transfusion. This has to be done in children on the high dependency unit, and really we want to avoid ventilation if possible, because these children will just sometimes take longer therefore to extubate. If they're very inflammatory, it may result in not being able to extubate them and them getting worse. Children with sickle cell disease can get severe infection. They are hyposplenic, definitely by the age of 5, and it is the most common cause of death of young children with sickle cell disease. Definitely in Africa, malaria is the most common cause of death in children with sickle cell disease, because malaria does not protect you if you are homozygous for sickle cell disease. There is a 600 to 700-fold increase due to susceptibility to pneumococcal sepsis, which is why it's especially good now that all children get Prevnar, and these children will also get the pneumococcal vaccine, the 23-valent, at 2 years of age and every 5 years after that. They also go on to penicillin, which is why it's the benefit of the newborn screening program that we pick these children up early, put them on penicillin early, not only just to counsel the families, but to ensure that they have adequate pneumococcal prophylaxis. So children get penicillin, they would get erythromycin if allergic, they get the pneumococcal vaccine. In addition, now again, hepatitis B is on the childhood immunization program, but that is something that they would get, as well as the flu vaccine every year. There was a randomized trial done many years ago now, which showed that there was a reduction in deaths if children were put on penicillin early. And this is the reason why, as I said, we put these children on soon after the newborn screening result, and often the first time they're seen in clinic. General management of infection. So if patients actually come in with temperature, we would take blood cultures, a chest x-ray if indicated. If they are unwell or septic, we would cover them with ceftriaxone, which covers all the pneumococcal bugs as well as Haemophilus and Salmonella. If there are chest concerns, we would add clarithromycin. If they're febrile but well, they could possibly have oral antibiotics, or they could go on to QDS penicillin. If they don't necessarily have to have intravenous antibiotics if they are not septic. If there's an abdominal focus, then always consider adding anaerobic cover. If there's osteomyelitis concern, now this is something which is quite interesting because most children, osteomyelitis is rare, but in those children who have high inflammatory markers, despite treating them with antibiotics, or their temperature doesn't settle, you may have to think about osteomyelitis. It's quite a difficult diagnosis to make because on MRI, many of the features would be similar to what you would be seeing if there was infarction. But actually, if there is temperatures and high CRP, then it may push you more towards the direction of osteomyelitis, as they are more prone to having salmonella bacteremia in view of being hyposplenic. So just in terms of neurological issues, previously 11% of children with sickle cell disease would go on to have a stroke before they're 14 years old. And over the last 20 years, we've been doing transcranial Doppler surveillance, which monitors those children's cerebral flow velocities so that we can pick up those who have high velocities and their risk of stroke. If a child does have a stroke, then this would be an indication for an urgent exchange transfusion, because giving an exchange transfusion within 24 hours of presentation will hopefully reverse any neurological sequelae and prevent further ones. So now we have a transcranial Doppler surveillance program, which we do between the ages of 2 and 16. This is a non-invasive technique where we look through the temporal bone, and various trials have shown that if these patients who have high velocities, which is an indication of stenosis, if they go on to receive transfusions, then that will reduce their risk of stroke, because just bringing the sickle percentage down will allow for that stenosis to improve, and therefore the Doppler velocities to improve, and that risk of stroke to hopefully will be removed. So what are the indications for blood transfusion? Generally, blood transfusion in sickle cell disease is rare. We would really do that not for an uncomplicated painful crisis, even if a patient drops their hemoglobin to 60, but they have a good retic response. We tend not to transfuse those patients, as they are able to make red cells and they will go back to their baseline once the acute event is over. However, if they develop a parvovirus-induced aplastic crisis and end up with low reticulocyte counts, which is why it's so important to check this, then these patients will need support with a blood transfusion. If they sequester into their spleen or their liver, they will definitely need a blood transfusion, and this could be a life-threatening event, and therefore the blood transfusion is an emergency. In the event of acute chest syndrome, to bring the hemoglobin up to 100, and if necessary, the patients will end up needing exchange transfusion. So in the event of a stroke, they'll need an exchange, and the reason why a top-up is not adequate is because you want to bring the S percentage down to less than 30% to reduce that risk of stroke or reverse it. In acute chest syndrome, if a top-up is not adequate, very occasionally if priapism does not go away despite all of the other measures, and regular blood transfusions are given to patients who have had a stroke. They will definitely need to go on to a transfusion program because the switch trial showed that hydroxyurea is inadequate to prevent ongoing vasculopathy, so these patients will end up needing to continue to have transfusions. And then the other reasons are increased transcranial Doppler velocities, although there is a lot of evidence that hydroxyurea can be just as good as transfusions in preventing conditional velocities becoming high. If a patient does have high velocities, we'll put them onto a transfusion program for a year to get them away from that acute risk and then transfer them onto hydroxycarbamide. Never transfuse above 100 grams per litre due to hyperviscosity. Splenic sequestration is a life-threatening event. This happens in younger children and often in sickle beta thalassaemics because they have persistent splenomegaly. So those patients in which the spleen has persisted are more at risk of splenic sequestration, and they can present with abdominal pain, rapidly enlarging spleen, and shock. And this is an indication for a transfusion, emergency transfusion, which is life-saving. And if they've had one event, then we would go on to consider splenectomy in these patients so that it does not happen again. Priapism is another complication that we see in some of our teenage boys and sometimes even younger, and this is a painful penile erection, and it may be stuttering or fulminant and go on. And the way to treat these patients is with epinephrine and urology support, who will advise in terms of whether any sort of intervention is required in order to preserve the penis. It's very important to consider those patients who are having surgery. Sickle cell patients are at increased risk of chest crisis and events during anesthesia and periods of immobility. Therefore, it's extremely important to flag these patients up. So they should have a proper preoperative assessment. If it's moderate high-risk surgery, then the haematologist will organise a top-up to 100 grams per litre prior to the surgery to be done electively in order to reduce the risk as shown in the TAPS trial. The lab has to be informed that the patient has sickle cell disease, as they will need sickle negative and KEL negative blood, as well as phenotyped blood to prevent the development of antibodies. They should be admitted the night before and have some hydration. And also the physios need to be involved in terms of post-operative incentive spirometry to prevent these patients develop chest crisis in the future. There are also chronic complications that these patients develop, including silent infarcts, delayed growth, puberty, renal disease, pulmonary hypertension, avascular necrosis. Hydroxyurea can be given early on to these patients to prevent both acute and chronic complications. It's a drug which has many effects, including raising fetal hemoglobin, which can be protective against complications and crises and hemolysis. Hydroxycarbamide is a drug which has many effects, but the main effect that we notice is that it increases fetal hemoglobin. It also changes the rheology of cells so that they don't no longer appear as sickle cells, and they have a normal shape and have increased red cell survival as well as increased availability of nitric oxide. You can see from this study that it has many, it's been used in many scenarios, and it's now being used from the age of 9 months in all children. It's well tolerated. It prevents pain. It prevents chest crises. It maintains or increases growth. It reduces transcranial Doppler flow velocities, and there is also some evidence that it might reduce silent infarcts, and the cognitive development of children is improved on hydroxycarbamide. It has many actions, and as I said, it can prevent all of the acute complications as well as improve the neurological outcome of children. It increases oxygen saturations, and it may prevent long-term damage if given early. Although that data is still being collected, there's no increased risk of malignancy, no evidence of affecting female fertility, and there are some concerns about spermatogenesis, but recent studies show that this could be reversible. It's cheap and effective. It's now offered to everyone over 9 months of age. It's recommended for everyone in the BSH guidelines which have been written, and have to keep the ongoing conversation with the parents and patients so that they're open to it and ready to accept it when they think that this would benefit their child. So in summary, pain is an emergency. You need to review the patient, review and review again. It can lead to life-threatening crises. Only few indications for blood transfusion, and never transfuse over 100 grams per litre. All protocols are available on the paediatric hemonc intranet under sickle cell disease, or through the NSSG hematology extranet, where you can find all of the protocols.